basic EKG terms, parameters, concepts, identify different types of tachyarrhythmias, mild versus severe symptoms, determine appropriate treatment for tachyarrhythmias. The practice, that's the student packet I talked about, and then the mega code, that's this dynamic practice, and that's going to be something you do in the station just with your crew members, all right? Okay, classifications of tachyarrhythmias, narrow versus wide. So QRS is less than 0.12 and QRS is greater than 0.12. That's one of your first determining factors of treatment. Okay, this is the classic ACLS algorithm slide. Difficult to read, I'm sorry about that. You can take it down to symptomatic versus non-symptomatic. So with symptoms, yes, synchronized cardioversion. And then from there, look, no symptoms is a QRS wide. Yes, treatment is going to be it's going to be ventricular in origin, so treatment's going to be amiodarone. If it's narrow in origin, then you're looking at something above the AV node, so adenosine, vagal maneuvers, then adenosine. And if you get too much adenosine, use the adenosine regimen. All right, sorry about that. Okay, so SVTs, secure is typically narrow, less than 0.12 seconds. That's, of course, in the absence of a bundle branch block. Paroxysmal, which means that it comes and goes, starting abruptly. And PR intervals are typically less than 0.20 seconds. The size of one small box in EKG is 0.04 for reference, okay? Okay, causes of tachyarrhythmias. Intracardiac causes versus extracardiac causes, something to think about. So, heart disease, heart valve disease, heart failure, enlarged heart, and congenital heart disease versus toxins such as drugs, alcohol, stimulant, stress, hyperkalemia. Okay, so don't forget about the H's and T's. Hyperkalemia, is one to certainly consider. It's going to be based upon history, of kidney failure, of course, and maybe being on dialysis. Most common causes of tachycardia that should be treated outside of the ACLS algorithm are dehydration, hypoxia, fever, and sepsis. Okay, so those are also causes of accelerated heart rates. Clark County Protocol inherently treats as the H&Ts, concentrating on causes that are already treated and should be identified early, such as hyperK or the toxins. And then hypovolemia, hypoxia, hydrogen, so ion, so acidosis, hypothermia, and T's, tension pneumo, and thrombosis. Okay. So supraventricular tachycardias. Intrinsic heart rate is greater than 220, so that's the intrinsic heart rate of a newborn. So SVTs greater than 180 in children, 150 in adults typically. You may or may not have CHF present. The rapid heart rate originating in the atrioventricular node, SVT, is caused by one of two mechanisms: reentry and automaticity. Reentry is AV nodal reentrant tach, and atrioventricular tach usually has immediate onset with sudden increase of heart rate. Automatic PSVT usually has gradual increase in heart rate and is due to an area of the heart that generates its own electrical signal. So, atrial tachyarrhythmias. That's the sinus tach. Greater than 100 beats per minute, regular PR interval, 0.12 to 0.20. Careful examination of P-wave will help determine origination of the rhythm. Common causes: normal exercise, fever, hypovolemia, adrenergic stimulation, anxiety, hyperthyroidism. Okay, so for cause, premature atrial complex. PACs may be secondary to Endogenous factors such as fever, hypovolemia, or hyperthyroidism, or often they are secondary to exogenous factors such as medications and various stimulants such as caffeine, ephedrine base, or methamphetamines. Treat as science text, treat the underlying cause. So secondary endogenous factors are fever, hypovolemia, and hyperthyroidism. Other secondary endogenous factors are caffeine stimulants, ephedrine-based stimulants, such as that. Common, may be associated with heart disease, can be a precursor to atrial attacks. Atrial flutter is common abnormal heart rhythm similar to atrial fibrillation, which is the most common abnormal heart rhythm. Both conditions are types of supraventricular, so above ventricle tachycardia, rapid heartbeat. In AFL, the upper chambers atria of the heart beat too fast, which results in atrial muscle contractions that are faster than and out of sync with the lower chambers. Okay. You got the classic inverted sawtooth flutter wave. The electrical signal that causes AFL circulates in an organized, predictable pattern. This means that the people with AFL usually continue to have a steady heartbeat, even though it is faster than normal. It is possible that people with AFL may feel no symptoms at all. Others do not experience symptoms, which may include, or others do experience symptoms, which may include heart palpitations, fast, steady pulse, shortness of breath, trouble with everyday exercise or activities, pain, pressure, tightness, or discomfort in the chest, dizziness, lightheadedness, or fainting. Okay, pre-hospital management. Atrial flutter is considerably more sensitive to electrical direct current cardioversion than atrial fibrillation, so it responds nicely to syncourgia. It usually requires a lower energy shock. Clark County, you start at 100 joules, however, for atrial fibs and flutters. Conversely, is relatively resistant to chemical cardioversion, so that's if you're advancing type treatment, and often deteriorates into atrial fibrillation prior to spontaneous return to sinus rhythm. So Clark protocol AFib flutter with the same, treated the same, no hypotension. So diltiazem 0.25 milligrams per kilogram, max 20 milligrams every 2 minutes. Avoid patients with beta blockers, contraindicated patients with WPW. Repeat dose 50 minutes later at 0.35 milligrams per kilogram, maximum 25 milligrams. If you do get conversion, you do a maintenance drip at 10 milligrams an hour. So this is one of the few ones that just get a maintenance drip. If hypotensive after diltiazem, they get calcium, right? So we give calcium channel blocker. So if you eat a little bit too much of that, we give some calcium to kind of balance things out. When stable, they get cardioverted at 100, 150, 200, and 200 joules. And of course, that's pre-dose for Versed. Atrial fibrillation is the most common irregular heart rhythm that starts in the atria. This SA node, directing the electrical rhythm. Many different impulses rapidly fire at once, causing a very fast, chaotic rhythm in the atria. Because the electrical impulses are so fast and chaotic, the atria cannot contract and squeeze blood effectively into the ventricle. Again, Clark protocol AFib and flutter are treated the same, unless with no hypertension. So again, it's the diltiazem regimen of 0.25 milligrams per kilogram. That's 20. Repeat dose is 50 minutes later at 0.35 milligrams per kilogram. That's 25. Again, if they're unstable, they are synchronized cardioversion at 100, 150, 200, 200. Clinical significance of atrial flutter and fib usually occurs in the setting of heart disease, hyperthyroidism, the cause of atrial fibrillation, may acutely precipitate myocardial ischemia or heart failure. Chronic inflammatory waves may induce cardiomyopathy and heart failure. Both can predispose to thromboembolic stroke. AV junctional reentry tachycardias. So this typically incorporates the AV nodal tissue. Approximately 10% of the population has a reentry pathway into the SA node that is undetectable by EKG. This pathway has an affinity to reproduce itself in the faster pathway than the slower pathway, causing AVNRT. This is triggered by PACs in the normal AV pathway. Slower with refractory conduction, therefore triggering the faster aberrant reentry site, which is a very fast repolarization time. Initiation of AV nodal reentry tachycardia is usually caused by PAC. Heart rates for AV NRT is usually greater than 120, seldom less than 150, and can be up to 250. Clinical manifestations: palpitations, becomes anxious and uncomfortable, exercise tolerance very low. Common etiologies for otherwise healthy people, factors that can provoke PSVT such as caffeine, hypoxia, cigarette stress, anxiety, sleep deprivation. Unhealthy patients, increased with coronary artery disease, COPD, and CHF. Sustainment of AV nodal reentry tachycardia. You see the fast and slow pathway depicted here. Accessory pathway of ventricular pre-excitation, so we'll focus on light. Not to be confused with reentry pathway. The accessory pathway from WPW is detectable on EKG via a delta wave. That's when they're not having the accelerated rhythm occurring though. So you can see this when the heart rate is at a normal rate, and then you have a diagnosis of WPW. If you're going into in and out of these ones of SVTs by the presence of this delta wave, which is shown there on the slide. Wolff-Parkinson-White is a type of pre-excitation syndrome which can cause reentry tachyarrhythmias via an accessory pathway. This pathway, called the bundle of Kent, apparently connects the atria to the ventricles, providing a second pathway for conduction between the two other than the atrioventricular node. This causes recognizable changes in patients' EKG and can lead to wide and narrow QRS changes. On rare occasions, WPW can deteriorate into VFib due to non-conventional aberrant ventricular conduction. AV node blockers should be avoided in atrial fibrillation and atrial flutter with WPW or history of it. This includes adenosine, diltiazem, verapamil, other calcium channel blockers, and beta blockers. They can exacerbate the syndrome by blocking the heart's normal electrical pathway, therefore favoring one-to-one atrial to ventricle conduction through the pre-excitation pathway, potentially leading to unstable ventricular arrhythmias. Okay. Clinical significance of AV junctional reentry tachycardias. Rarely life-threatening. May produce serious symptoms, dizziness, and could be fainting. Can be very disruptive to quality of life. Involvement in an accessory pathway can carry extra risk. AV node blocker should be avoided with WPW or history of it. Okay, so we just covered that. Treatment of stable reentry SVT. Okay, so start with vagal maneuvers. Okay, for PSVT, normal tachycardia, PAD, etc. For stable attempt vagal maneuvers, call up Valsalva. Carotid sinus massage, establish bilateral carotid movements. Do right carotid sinus massage, wait 1 minute, and do left carotid sinus massage if right is successful. If PSVT persists, adenocard, which is contraindicated in secondary block, reading block, allergies, or known WPW. So that's a big one, and that's based upon history. Caution with asthma, pregnancy, patients on Tegretol, diclofenac. Ineffective in AFib flutter. If PSVT persists, stable, i.e., no hypertension, rapid ventricular rate, you get diltiazem, 0.25 milligrams per kilogram, max 20. And then, of course, the repeat dose, which is 0.35 milligrams per kilogram, max 25. They get the conversion to 10 milligrams an hour. The alternative to that one is verapamil, 5 milligrams IV, so over 2 minutes. They repeat 5 milligrams every 15 minutes per PRN to max of 30 milligrams. Cautions: used only with narrow complex SVT or supraventricular dysrhythmias. No wide complex tachycardia is not used if patient on oral beta blockers. Okay, so it's a good idea on this one. The protocol, the Clark-County protocol on dysrhythmias, we'll put this in that also in the study resources, so take a look at that. I know I'm going through this stuff pretty quickly. And I'll also attach a sheet on dysrhythmias that explain reading the material that will explain some of these dysrhythmias in greater detail, especially the WPW. That one's kind of difficult to explain in this, so I think if you read through that, that'd be helpful, I would say. Differential diagnosis of regular narrow QRS tachycardias. So re-entering SVT, incorporating avian little tissue. SVT mechanisms confined to the atria, sinus tach, flutters, other regular atrial tags. Looking at those. Determining AV nodal participation in SVT by transiently depressing AV nodal conduction. So vagal maneuvers, clove carotid sinus massage, Valsalva, bearing down, the facial ice packs, the dive reflex. Adenosine 6 to 12 milligrams IV. If SVT breaks, re-entry mechanism involving AV node is likely. If atrial rate unchanged, but ventricular rate slows, SVT is atrial origin. So if SVT breaks, it's likely AV NRT, usually gradual onset. Likelihood that treatment with medication to carotid inversion is needed. If atrial rate unchanged but ventricular rate slows, likely it's SVT. Treatment of underlying causes or approach to care for this rhythm less symptomatic. So very rarely recurrent. Ventricular tachyarrhythmias. PVCs are fairly common in normal EKGs, but are also seen in the setting of heart disease. Monomorphic VTAC often implies heart disease, but can sometimes be seen as structuring in the heart. Polymorphic VTAC results in myocardial ischemia or conditions of prolonged ventricular repolarization. Electrolyte problems, hypoxemia, and drug toxicity can cause PVCs and VTAC. Ventricular tachycardia, or ventricular fibrillation, causes most of the sudden cardiac deaths in the United States at an estimated rate of approximately 300,000 deaths per year. VTAC refers to any rhythm faster than 100 or 120 beats per minute with 3 or more regular beats in a row, rising distal to the bundle of his. The rhythm may arise from working ventricular myocardium, the distal conduction system, or both. Signs and symptoms: history. Symptoms of VTAC include the following: palpitation, lightheadedness, syncope, chest pain, anxiety. Upon physical examination, during VTAC falling may be observed hypotension, rapid breathing. Signs of diminished perfusion include diminished level of consciousness, pallor, and diaphoresis, and high jugular venous pressure. So monomorphic VTAC, it kind of looks the same. Monomorphic VTAC is a form of ventricular tachycardia with the shape of each beat on the EKG matches each other. The common cause is tissue scarring from a previous heart attack. Ventricular tachycardia is stable with adequate perfusion, so we're looking at the treatment. High flow O2, IV, 12 lead prior if possible, 2 and after treatment conversion. Trial of adenosine may be appropriate if minor signs and symptoms to rule out an SVT. Amiodarone, 150 milligrams, so we're looking at a QRS greater than 0.12. Amiodarone, 150 milligrams over 10 minutes. Repeat 150 milligrams after 10 minutes. If VTAC reoccurs, VTAC persists, cardiovert as an unstable VTAC. VTAC refractory or cassage or tricyclic overdose. Person gets mag sulfate 2 grams IV slow over 5 to 20 minutes. So you're diluting that in 50 cc bag. Right, we're just kind of run that wide open and get that in, I think, in 9 minutes. Polymorphic VTAC. Confirm, check leads for artifact, treat the patient, requires immediate defib. The long QT interval observed during sinus rhythm, VTAC is torsades. May choose to immediately use mag sulfate in that instance. In the absence of prolonged QT interval, the most common cause of polymorphic VTAC is myocardial ischemia. So unstable VTAC, O2 by flow IV, Versed, prior sync cardio, 100, 150, 200, 200. Recurrent VTAC or persistent, that one gets down to yoga, 150 milligrams over 10 minutes. And that VTAC refractory or torsades or TCOD. And reverted to nag sulfate 2 grams IV slow with 5 to 20 minutes. So all the bags are mixed the same, right? You try to run them in 10 minutes. Clinical significance of PVC's VTAC can be tipped off to underlying cardiac, respiratory, metabolic disorder. VTAC may but need not invariably lead to a hemodynamic collapse or more life-threatening ventricular tachyarrhythmias, increasing the risk of cardiac arrest. Ventricular fibrillation. Defibrillate witnessed defib. EKG paddles quickly determine defib VTAC. Defibrillate at 200, escalating energy dose of 3 to 360. Is appropriate for subsequent defibrillations. Children, 2 joules per kilogram per shock, 4 joules per kilogram subsequent shocks. Okay, so let's see this. Atrial fibrillation with graphic induction, the accessory pathway degenerating to VFib. Example of that. Diagnosing regular wide QRS tachycardia. Showing the notched downward deflection kind of favors VTAC, smooth downward deflection favoring PSVT. There's an example here of sustained aberrant conduction, so let's go right to VTAC. Clinical clues to basis for regular wide QRS tachycardias. VTAC does not invariably cause hemodynamic collapse. Patients can be conscious and stable. History of heart disease, especially prior myocardial infarction, suggests VTAC. Occurrence in a young patient with no known heart disease suggests SVT. So 12-lead EKG, a patient stable, should be obtained. Artifact mimicking VTAC, so check the patient. That's all we see, the classic one. Treatment rules for wide complex tachycardia. If they are unstable, shock them. Treat the patient, not the rhythm. Look for hyperkalemia and TC overdose from history. QRS is greater than 12 milliseconds is probable VTAC. So it's more likely than not VTAC. AV dissociation VTAC. Older patient can fast, probable VTAC. Previous MI fast, probable VTAC. If they are unstable, shock them. So, one of the classes that we had in August, one of the doctors from the NPD's office, what we were talking about, what's the most likely way to make an error on one of these calls, and really it's failure to sync cardio an unstable patient, right? Where you kind of, for whatever reason, you fail to recognize that and you fail to quickly get on that. So that's really the one you need to look for. It does kind of stable, unstable is a very good starting place, and take the treatment from there. Okay, good. So self-study again is going to be a self-study of the protocol. That's going to be posted. Self-study of this info sheet on the different types of tachycardias. It's a pretty good short read on the different types, kind of help you understand them a little bit better. Do the student packet, which is the EKG recognition, and just keep that one for yourself. You don't need to turn that in. Do your firehouse codes, and do a mega code with your crew. ALS mega code. Just go over. Make sure you go over the switch, and that all the EMTs there are familiar with how to use a monitor. Be aware of your compression rate. Use that metronome, the CPR button, to give you the timing on that. That's actually kind of important. So you get a nice most times compressors will tend to go a little bit fast. And so just, go through a mega code with your crew, and kind of just feel comfortable, running the cardiac arrest call. Okay, hey, thanks for listening. Take care.